Today, Dr. Nitin Abraham will be presenting the case. I request Dr. Munir to invite the examiners. Over to you, Dr. Munir.
Good evening. Thank you, Bogan sir. Today's PG Ampok YMO training session 31st. So today the case presentation will be done by Dr. Nitin Abraham. He's the third year resident DRNB from Lakeshore Hospital. And we have two eminent examiner. One is Dr. Sunu Sirieksa. He is from Amla Hospital, and Dr. Lashmi Haridas Madam. She's from RCC Trivandrum. Over to you, sir.
Hi, good evening, everyone. Dr. Nitin, that is his name, no? Yeah. Dr. Nitin, can you hear me?
Yeah, I can hear you, ma'am.
Okay. Sunu, can we start?
Yes, we can start. Please go ahead.
Yeah, Nitin, please go ahead.
Okay. Good evening to all. I'm Nitin. I'm a final year DNRB from Lakeshore, and today evening I'll be doing the case presentation for this Ampok meet. Okay.
Nitin, you're final year?
Yeah, final year. This is a 24-year-old male student who presented with complaints of breathlessness since 2 days, abdominal pain of 1 week duration, and right scrotal swelling of 2 months duration. Coming to history of presenting complaint, he had a trauma, he had a trauma to testis while cycling about 2 months back, and he developed a painless total swelling. It was slowly increasing in size, but he had not disclosed it to his parents. They had not consulted a doctor for that. Then he developed abdominal pain 1 week back. It is right upper quadrant pain, dull aching type. It was present all the time. There were no relieving and aggravating factors. And he also developed breathlessness since 2 days. MRC grade 4 breathlessness. It was worsening since then. He was admitted in another hospital and put on non-invasive ventilation because of the worsening breathlessness. There was no hemoptysis, no cough and expectoration. Then there is no history of back pain, no loss of weight, no fever, no headache, no vomiting, no seizures. Coming on to past history, no history of any surgeries or any significant medical.
Wait, Dr. Nitin, wait. Dr. Lakshmi, you wanted to ask something.
No. What was his age? I missed it.
23.
23 years. Okay, so we can go ahead. You will finish the history and go on for discussion. Okay, so now.
Coming on to past history, there is no history of any surgeries or any past significant medical history. Coming on to family history, there's a history of colon cancer in his grandfather. Personal history is a student, unmarried, no history of smoking, alcohol intake, or drug abuse. He takes a mixed diet. Summarizing the history, this is a 24-year-old unmarried male presenting with painless right testicular swelling of 1 month duration, right upper abdominal pain of 1 week duration, and breathlessness of 2 days duration.
So what would be a provisional diagnosis? Because we are dealing with an oncology, we will confine to oncology. So what will be your provisional diagnosis here? After hearing this history alone, before examining him?
My provisional diagnosis would be, first differential would be a germ cell tumor of the testis.
Mhm.
Second would be a testicular lymphoma.
How do you defend your testicular lymphoma part? How what are the percentage of chances do you give for this 23-year-old to have a lymphoma?
Testicular lymphoma is unusual in this young age, more common in older age group. So my first differential will be a germ cell tumor of the testis.
Sorry, what was the second differential?
Testicular lymphoma. So
Why? Any other thing that you want to consider?
then sarcoma of the, paratesticular sarcoma.
Okay,
Bit
then.
more.
Then
What is the age group for a testicular lymphoma?
testicular lymphoma is towards older age groups. This 23-year-old, it is unlikely.
Okay, so I think somebody is putting the messages in the chat box. I think please refrain from answering in the chat box. You can answer it in with yourself. Let him try to answer the questions. I think leukemia can also be one possibility above lymphoma might be.
Okay.
And you mentioned that there was a history of colon cancer. What is the significance of that?
Colon, certain, Peutz-Jeghers and Carney, they more with, sertoli ladies, sertoli ladies tumors.
Certain these things can. You mentioned that the boy does not have a drug abuse history. Why was that specifically mentioned? Is there anything related to this?
Testicular malignancy is associated with marijuana, cannabis
Okay.
abuse.
Dr. Lakshmi, anything? Or we shall proceed?
In the category of germ cell tumor, with this history, with the history you got, what could be the subtype? It might not be, it need not be, but just for discussion part, in this STOMI course, which histology would you anticipate in this patient?
In this patient, I would favor non-seminomatous germ cell tumor.
Why?
Yes.
The age is in his 20s, early 20s. Seminoma more of like 30s or 40s, little more older.
Yes. Because he's having a STOMI history, it might be choriocarcinoma if proved so.
Okay.
If proved. Because he doesn't have any bleeding manifestation, there is no other second point to corroborate your choriocarcinoma part if it is so. But still, in the STOMI course, always think of choreo. Because he had 2 days of breathlessness, 1 month history, like that, no?
Okay.
Okay.
What is cryptorchidism? What is cryptorchidism?
Cryptorchidism is testis descent into the scrotal sac, remains in the abdomen or in the inguinal canal.
Did he have such a history?
No history of cryptorchidism.
Did you mention that in the history?
I just said about any surgery, sir. No, orchidopexy was not done. No history of any surgery. Orchidopexy was not done, sir.
So what is the procedure for patient with with cryptorchidism having a testicular malignancy in the long run?
It's 5 to 6 times more than in general population.
What are the other risk factors for germ cell tumor?
Other risk factors are family history in either in brother or father.
Yes.
Then other syndromes like Klinefelter's testicular feminization syndrome.
Yes. So where do you put the risk factor? Is the risk factor more when the patient's sibling has a disease or if the first degree relative, like father had a disease?
It is more with a sibling.
It is more with the siblings. It actually double with the siblings.
Double with the siblings.
Double with the siblings.
So would you ask to take a screening biopsy for the brother if he has? If he has a brother,
Yeah.
suppose he has a brother and if he is asymptomatic, after his treatment, would you suggest for a screenings procedure for the brother? Because familial cancer is gaining more and more importance of late. So naturally, they will come and ask you, what are the chances that the brother should be screened or the brother should be tested or do something for that?
We
More
wouldn't do,
relevant if it is a twin brother.
Exactly.
but we wouldn't do it. It is not in the recommendation. Also, we will violate the lymphatics if you go and try to go to transportal biopsy. If you do, you will violate the lymphatics and not given in the guidelines also. Like
Yeah,
What do you
Dr.
mean by this violation of the lymphatics?
usually, the lymphatics, the landing zone, right testis to the paratic node, left. Sorry, right
No.
testis to the inter-iotocaval node and left to the paratic node.
Yes.
But if you violate the scrotum is involved, scrotal sac, it can go to the pelvic nodes.
No.
Of the
If the
inquiries.
surgeon wants to do a biopsy, they will do only with a high inguinal approach. What they do is that they put an incision as like they're going to do a high inguinal orchidectomy, and they will deliver the testes out, do a biopsy, and put that thing back. That is how they do. They will not do a scrotal violation anyway.
Suppose
But even if high inguinal approach was done or not, is routinely done or not, that will answer Sunu's question. It is not regarding violation. Would you do or not? Or in other sense, what are the indications for doing a biopsy? Is there a screening?
No screening guidelines for testicular malignancy.
Unless some very high risk patients like a twin brother or so, some people might suggest that if there is a twin brother, you could think about it, about screening.
For that, what do you do in that case? In that case, what would you suggest? Is it ultrasound or some other thing, CT, or what is the mode of, if at all you want to do, if at all want, I would not use the word screening, but rather the meaning is actually screening only, like whether that person is harboring a disease, whether you want to actively go and look onto. So what are the modes of investigation in that case?
I can do an ultrasound of the scrotum.
Hmm.
Ultrasound of the scrotum can be done.
Yeah.
Then
And you look for, what do you all look for? Any lesion? Definitely then.
any lesion in seminoma, usually homogeneous lesions are there. Non-seminomatous, maybe heterogeneous calcification, cystic lesions.
Yeah. Then anything regarding the volume?
Increase, larger, enlarge size.
No. Testicular atrophy less than 12 cc. With all risk factors which point to that this person might be harboring a disease. But if till when you not see a lesion there, you will not intervene nowadays. These all guidelines go to look whether the patient has a TIN inside him. Testicular intraepithelial neoplasia. Nowadays, nobody go on to look all that, but theoretical part, yes, if you have a twin brother, you would probably recommend all that depending on your case.
Okay.
What is this TIN that Madam mentioned now? Or GCNIS or new terms? What is that?
Yeah.
Germ cell in intraepithelial GCINS.
What is the significance of that? Suppose somebody did a biopsy for a treatment of fertility, infertility treatment or something like that. Somebody did a biopsy and the biopsy report showed a GCNIS. What does that signify?
It's a pre-malignant lesion, so more chance of conversion to a.
How much chances of conversion? Okay, is GCNIS, this pre-malignant condition, always present in before every GCTs, or can a GCT appear de novo?
GCT can appear de novo also. Not all.
No, usually most of the GCTs are preceded by a new intraepithelial condition. This is, yeah, and the chances that it will progress to this thing is around?
Don't know, sir.
Okay, fine. Shall we go to the examination?
Yes. The answer is 5. It is very easy to remember. 5% at 5 years and
5%
7%
out,
at
yes.
7 years. Very easy to remember. That tail risk how goes into malignancy. Okay, you can go to your examination findings.
Okay, ma'am. Coming on to examination, performance status 4. He was on NIV, moderately built and nourished, BP of 140/80, pulse of 126 per minute, respiratory rate around 36 per minute, no pallor, jaundice, clubbing, generalized lymphadenopathy, and pedal edema.
Mm.
Examination of the abdomen. Abdomen is flat, no scars, no dilated veins, no shifting dullness. Hepatomegaly present 6 centimeter below the costal margin.
Mm.
Firm, smooth surface, borders are regular, and no supraclavicular lymph node enlargement. Then there's a right scrotal swelling, 7 into 6 into 5 centimeter, hard in consistency. Spermatic cord was not thickened. Testis is not separately palpable. Scrotal skin is normal and hernial orifices are normal. Coming on to examination of the respiratory system, trachea is central, chest wall was moving symmetrically, breath sounds heard bilaterally, bilateral rhonchi and crepitations were present, no supraclavicular lymph nodes, no gynecomastia.
Okay. Other than hepatomegaly, no masses are palpable in the abdomen?
No other masses palpable in the abdomen.
Did you mention about the inguinal hernia orifices?
Hernial orifices are normal.
Opposite testis?
Opposite testis was normally fit. I didn't mention it, sir.
Most important
Very-
thing, yeah.
Very important.
Okay, ma'am.
Okay, then
Respiratory system, no supraclavicular lymph nodes, no gynecomastia. Then coming on to cardiovascular system, both heart sounds heard normally, no focal neurological deficit. Coming on to summary,
Any question finding? If not, you can summarize.
say 24-year-old unmarried male, presenting with painless right testicular swelling of 1 month duration, right upper abdominal pain of 1 week duration, and breathlessness of 2 days duration. On examination, had tachypnea, tachycardia, and poor performance status, requiring non-invasive ventilation. Bilateral krebs and bronchi were heard, and 7 into 6 into 5 centimeter hard right scrotal mass, hepatomegaly 6 centimeter below the costal margin, with small smooth surface and regular borders.
what is the importance of marriage in this? For CA breast and all, you mentioned postmenopausal, premenopausal. Why do you want to specifically mention unmarried male here?
Because there is a chance for infertility per se due to the disease as such, and due to the treatment also, what can cause.
Do you think that your treatment might differ if the patient is married or unmarried? In ovarian, sometimes ovarian cyst or malignancy, sometimes you go for a fertility sparing surgeries. Is there something like that you can do here?
No, sir. One thing you can do semen collection. No.
If the family is not completed
Not
or
complete.
not. Okay. Okay. Go ahead.
So your provisional diagnosis, again testicular GCT.
Testicular
So
disease.
you have the reports of this patient? You have the real reports of this patient?
Yes, ma'am.
How before that, how do you work up? You are sitting in the ER department and receiving this patient. You got the history very fast, got the examination findings very fast. What would you order first?
First, I'll do the routine blood investigations. Then
patient is very sick, PS4.
PS4.
What is your priority?
Of chest X-ray.
Yes.
First,
you first stabilize the patient.
Stabilize the
First stabilize the patient. That is the word the examiner wants from you. First, you stabilize the patient, get the history done. And once after you stabilize the patient, it's not like a pakka stabilization, but once you take care of the vitals, you go on for your investigations. Okay, then
Then
what investigations?
I'll take a chest X-ray.
Okay.
Then routine blood investigations. CBC, LFT, RFT. Then markers, AFP, beta HCG, LDH, uric acid, electrolytes, sodium, potassium, calcium, phosphorus.
Okay.
Then
Why do you
I'll
look on to calcium phosphorus as a first priority?
because tumor lysis also I'll need to rule out tumor lysis. One differential is a lymphoma, so I'll
Okay.
think about
Okay.
tumor lysis syndrome also.
Okay, do you have the reports with you?
Yes, sir. CBC, LFT, RFT were within normal limits. AFP was 903. Beta HCG was 24 lakhs, 50,000.
Yeah.
LDH was 2,540. Uric acid of 4.3. TSH 0.23. Free T3 1.2 and free T4 0.92.
Yeah. So the natural history which you narrated, no, that is the actual history of choriocarcinoma syndrome. That is the thing, because you will not get the mass. That is why I specifically asked you, didn't you get a mass? Usually choriocarcinoma goes directly into the lungs and cause all these kind of stormy pictures. Normally they won't have time to develop a mass in the abdomen unless it is an AFP raising tumor which builds on like that. That is a clue towards your tissue diagnosis. Okay, so you got a high 6 lakh, 6 lakh.
24 lakhs.
24 lakhs. Okay. So what is that called then? What is your patient's status called? Condition called?
Choriocarcinoma syndrome.
Yeah. So what next? You're done with the investigations? Only X-ray you have taken?
I'll do ultrasound of the scrotum and CT, CT of abdomen.
You got the CT of the patient also done?
Yes, sir. I mean, after I got it done here. First we did an ultrasound, then later we did a CT of the abdomen.
Okay.
What was the finding there? CT abdomen. What is the finding here?
CT abdomen showed multiple liver lesions, ma'am.
Okay.
Then also CT abdomen and chest multiple lung lesions also.
Okay, you got in the chest X-ray itself. Most probably you will get in chest X-ray itself, no? Okay. Then other investigations, anything you missed out? Any organ-based investigations you missed out?
Then last we did MRI brain also.
So what was that?
MRI was normal, essentially normal.
Normal. Okay. So would you go ahead with the biopsy?
In this case, actually, we did a biopsy. Then, without waiting for the result, we started.
From where? No. From where did you do the biopsy?
We did. It was a large scrotal mass. We did a biopsy from the scrotum. Then we went for, without waiting for the results, we started treatment.
Okay. But actually, it's not very highly recommended, because once you get them, that is the value of having the tumor markers with you. This much of an elevated value, there is no need. We will not wait for a biopsy report to have, because it is a choreo also. In case, because you said the testicular mass is very hard, no? That is because it has already had bleeding within it. That is a usual scenario.
Okay.
They will have bleeding inside. They will have already formed a hematoma. So that is why a routine GCT test is not that very hard. Since you said it is a hard swelling, it is a hematoma. It is
And I think the liver CT was also showing some hemorrhage, isn't it?
Hemorrhagic,
Was there a bleeding in the liver?
hemorrhagic
So,
met.
okay. A very confident radiologist for doing a biopsy. Okay, then
Anyway,
then
next.
the treatment plan.
And what did the biopsy say? Since you did the biopsy, what did it say?
Biopsy showed it came as
What is?
germ cell, non-seminomatous germ cell tumor. It was beta HCG, OCT5, SAL4, and PLAP were positive. CD30 was weakly positive. Glypican GATA3 negative.
Okay. So how do you proceed?
Wait, what does the IHC says?
It's mixed germ cell tumors. So
What are the components? What are the positive? Beta HCG is positive, OCT5, SAL4,
SAL,
PLAP are
PLAP
positive.
Then
So what does this IHC suggest? Any idea what are the specific IHC for the specific histological types?
yeah, OCT5 and PLAP for seminoma.
Okay. OCT3 or 4?
OCT3 and 4 also positive seminoma, sir.
Seminoma, but more for? Might be embryonal carcinoma also. Okay, then SAL4?
SAL4 can be positive in all germ cell except tertoma.
It's not so specific. Okay. Then
CD30 in embryonal carcinoma.
okay, good. Then
Glypican in yolk sac tumor.
okay.
GATA3 also in choriocarcinoma. Positive.
Okay.
Positive.
So impression was 1 and 2, IHC and true cut biopsy, malignant germ cell tumor with extensive necrosis. Okay. Next.
Only this much, sir.
So in summary, it is a case of?
The case of metastatic non-seminomatous germ cell tumor, sir, with liver and lung mets.
Okay, liver and lung mets, no brain mets.
No brain mets.
Okay, next, how would you plan his treatment? He is PS4
in this
on
patient,
NIV.
yeah. In this patient, after taking the biopsy, without waiting for the results, we started on chemotherapy with carboplatin and etoposide. Carboplatin, day one, we gave a flat dose of 300 milligram. Etoposide, day 1 to day 3, 100 milligram.
So suppose, how would you proceed with the case of metastatic germ cell tumor? Forget about this being a PS4 patient. If it was a PS2 patient or something like PS1 or 2, you got the biopsy report. He is having some mets in the liver and some mets in the lung. How would you plan your treatment? What are the things that you would look into planning your treatment?
In this case, its stage would be 3C. It's S3 markers are there.
S3 markers. Why do you say S3 markers?
Beta HCG level is 24 lakhs, sir. More than.
When do you check for the markers to classify it as S1, S2, S3?
That after surgery, 3 weeks after surgery.
Okay. So you haven't done a surgery. So it's not a proper S1, S2, S3, but still looks like okay. And then staging wise, you told that it is around stage 3C. What else do you want to look at?
Stage 3C recommended is chemotherapy with BEP into 4 or VIP into 4. Checking.
What is the risk group of this patient? Have you heard about a risk grouping?
Yes, it is poor risk.
When would you apply the risk group to a GH? Do you apply the risk group for all germ cell tumor patients or some certain patients?
Only in advanced stages, more than from 2C onwards.
What is stage 2 onwards? What is stage 2?
Stage 2 is metastasis to the retroperitoneal nodes. That is
In your nodal metastasis,
Nodal.
if it happens. Dr. Lakshmi, anything to ask? You're mute. Dr. Lakshmi, you're mute.
Okay, sorry. You do your stratification based on what all parameters? 3 parameters. 1, 2, 3. What are they? One?
One is the location of the primary.
Yes. Second?
Second is the markers.
Yeah.
Then the metastasis, non-pulmonary or whether it is pulmonary or non-pulmonary vessel mets.
Yeah, because a patient has a high beta HCG and liver metastasis upfront.
Okay.
Naturally, it will go into poor risk. Keeping in mind that primary surgery was not done for the PS4 patient. The patient for which Sunu was asking PS2 with little bit of dyspnea or even no dyspnea with liver mets. How do you proceed? Not a symptomatic patient with a high beta HCG value. 1,50,000 something. AFP is 500. LDH is 10 times higher than normal. If such a patient comes to you, what would be your treatment plan? Again, it is poor risk.
Okay. In this patient, I'll go for high inguinal orchidectomy.
Okay.
Then check tumor markers 3 weeks after surgery.
So the patient came to you with a CT thorax and abdomen, and they can do anything. They came and asked you, doctor, do you want to do a PET scan to know more about the tumor?
No, we won't do a PET scan. It doesn't give any additional information.
Okay. PET, if you are going to do if you are going to treat the patient with a high angle octane for a already metastatic patient, you need to look the markers 3 weeks. You need not keep the gap as 3 weeks, or there is no gap like that. When the patient is metastatic, you can wait till the surgical morbidity acute problem is over, repeat the values and start off your treatment. And for in a patient who was having a very poor GC as a newer patient, how do you modify your treatment?
In this patient, we gave shortened course like carboplatin etoposide. Day 1, carboplatin 300 milligram and etoposide day 1 to day 3, 100 milligram.
Okay, why did you choose carbo in this patient? Why did you choose carbo?
Because cisplatin hydration would be needed. So
Okay.
in emergency, we gave.
Okay. So in an otherwise fit patient who you think can tolerate cisplatin, what would be your first chemo? What is that called? What is an initial low dose chemo which we give in this situation called?
Preface.
Yeah, prephase chemo. Overall, which drug do you think it is most important in GCT treatment? If you are given if anybody gives you a chance to choose only one drug for GCT, which drug should you choose?
Platinum, cisplatin.
Platinum. Why cisplatin? What is the mechanism of action of cisplatin in germ cell tumors? Why is it so much linked to the durability part? When you talk on GCT, testicular GCT specifically, you actually told if in your histology part, histopathology part, that is a clue.
One thing is, platinum transporters
Yes.
it's a platinum transporter. It accumulates in the cells. Platinum.
Can you be a bit more specific? You're almost there. That so many reasons are there, but the main point related to the tumor behavior is this. But it can be more specific. You got it in the IHC because OCT4 or 5 markers are highly expressed in the surface of the GCT cells, and cisplatin works via these transporters to get into the cell.
Okay.
So it is an easy way through for them to get into the cell and kill them. So that is why cisplatin is the most effective one in germ cell tumors. So what is the ideal prephase chemo? Ideal prephase chemo given in the guidelines?
Ideal prephase is cisplatin, etoposide cisplatin, 3 days, 20 milligram per meter square into 3 days, and etoposide 100 milligram per meter square, 3 days.
Okay, how many cycles would you give? And why do you give that? Why do you give that?
Prephase you give, otherwise, to prevent complication, it can hemorrhages can occur and bleeding into tumor sites. To prevent that, we give prephase.
Prephase, because to prevent an immediate tumor lysis and imminent bleedings. Imagine this patient had MRI detected brain mets, 2 lesions, one in temporal lobe, one in the parietal lobe. How do you alter your treatment? Or would you continue with your chemo?
MRI, if brain mets were there, I'll see if he is symptomatic.
Imagine he is not symptomatic. MRI detected.
I'll interrupt and give radiation to.
Why do you interrupt? Why do you interrupt?
Brain mets can we can develop seizures, and also we need to.
Can you
You
give
need to
concurrent
adjust
cisplatin?
Yeah.
Do you
Any
use concurrent
contraindication?
cisplatin anywhere?
Concurrent cisplatin.
Is there any harm giving cisplatin while radiation is going on?
No. We can use. We use.
You said you have given etoposide and carboplatin. So are these two, or imagine cisplatin. So are these agents contraindicated concurrently with RT?
No. We give in small cell lung cancer and all.
So would you give concurrent or break up? Break your chemo part and go for RT.
We can give concurrent, but I'm not sure about the toxicity. If it will be more of maybe we can give concurrent, ma'am.
You can
The
give
patient's
concurrent.
patient's family was very apprehensive, and they got the report that there is metastasis all over. So they came and asked you. So it's almost a gone case, doctor. So why do you want to treat him? He's almost having metastasis everywhere. So why do you want to treat him? Shall we just send for palliative care? What would you suggest to them? What are you looking at when you're going to treat this young boy? Outcome.
Even it is advanced on NSDCT, but still it is chemotherapy sensitive. So when it is stage 3C, you have responses are about 40 to 50%.
Based upon which study?
I don't know, so it's study. I don't remember.
40 to 50% chance of cure was present in the initial studies. It is a little bit even better with better care and all those things. So you have to tell them that this is still a curable disease and it's not a purely palliative. Now you started treatment. How many cycles would you give? The first cycle he tolerated nicely and he came out of the NIV. Did he come out of the NIV or is he still in the ICU?
He's still in the ICU, sir.
How many cycles over? How many cycles are over till now?
Only one we gave, prephase, only one.
Is he still on NIV?
We had removed the NIV, but he developed again hemorrhage into the lung and also. We had to again put him back.
Okay.
Unfortunately. Suppose he completely got clear, means like he improved very much after the first cycle and he was off oxygen, you shifted him to the room, completed around 20-21 days. What's your next plans? Definite plans for treatment?
I'll switch over to BEP chemotherapy regimen.
His brother was working in IT field and they searched a lot in Google and told that he's already having so much of lung mets. There's some funny drug is there which can produce lung problem also. Do you want to take that? he comes and questions you after asking Dr. Google, what would you say? Is there any problem with BEP like that?
Bleomycin can cause pulmonary, causes more chance for pulmonary toxicity. So
And how much percent?
So 30 to 40%.
30 to 40%. A little bit more, I think, yeah. I think GCT it's around 10 to 12% or something like that, and I think Hodgkin's it's a bit higher, around less than 20% also. So what would you say to them? They are concerned about the bleomycin lung toxicity. What would you tell them?
Okay. He already has lung mets. Then the regimen is the VIP regimen. That is proved to be equivalent to the BEP.
What is that?
In VIP, we use etoposide, ifosfamide, and cisplatin.
How many cycles for him?
Four cycles of VIP.
Okay, you've got the first EP done at your side and you're waiting for the next week. Imagine that time has come and you're repeating the markers. You find the markers are high, still 6 lakhs. I have a similar patient now, that is why. I have 6 lakhs beta HCG, still 6 lakhs next week. How do you approach?
We see if there is a log reduction.
Hmm.
If there is a log reduction, we can continue with
There
chemo.
is no log reduction. The value is almost the same. Next week, what goes in your mind? The tumor is very lyseable, no? So how do you approach?
But then maybe the beta HCG is coming out from the cells, so that can be false positive.
It is not false positive, but another phenomenon. What is that? It's a what is that called? Tumor? It's called a tumor flare. So we shouldn't alter your treatment based on your next week value. It will naturally come down as depending on the T half of the tumor marker. What is the T half of beta HCG?
Beta HCG is 24 to 40 days.
AFP?
AFP about 5 to 7 days.
Okay. So how do you proceed? Your next week value is high still, so you will continue with your planned treatment. So the patient is having a fluid overload problem. So how do you manage? Patient is still in NIV or maybe in a minimal support. So in day-to-day practice, when you're giving a patient, you're putting a patient VIP, what all parameters do you look for in the daily rounds?
Pardon, madam? On NIV, patient on NIV.
Patient on NIV he should have an oxygen support to maintain his vitals. Patient has been put on VIP as per the protocol. Daily, what all do you look for?
I look at the blood gases, PO2, PCO2.
Okay. Okay. Day-to-day management, what all do you routinely ask to the sister? Sister, how much is this? What all parameters do you look for?
FiO2, if I can reduce the FiO2.
Okay. Patient's parameters.
SpO2, oxygen saturation. Then.
Okay. What do you look at the output? Daily output?
Intake output chart also.
Intake output is very important because the patient's lung is already wet with the blood. So we don't allow the blood to sleep when you be there. You should always put the patient on negative balance, at least plus minus. Okay, then of course you're giving ifosfamide. So what specifically there related to renal?
Hemorrhagic cystitis.
How do you manage that? He is having hematuria. How do you manage?
We give mesna along with ifosfamide.
Yeah.
hemorrhagic cystitis. No?
What if hemorrhagic cystitis happens despite giving Mesner? You're working in a hospital where there is no urology. How would you do?
What would be the local treatment?
Cystoscopy and
Okay, cystoscopy. There is no urologist there. No urologist in your hospital. Can it be due to the tumor in the bladder which we did not know?
yeah, there is tumor in the bladder. It can also bleed. So
Okay, please look on to how do you manage hemorrhagic cystitis, sir?
Now, suppose you completed 4 cycles.
okay, sir.
You have planned for 4 cycles only. You completed for 4 cycles.
Yes.
The markers have come down 24 lakhs. It has come down to around 50,000. AFP, how much it is? 900. It has come down to around, say, 100.
Okay, sir.
What would you do now? 4 cycles completed, 3 weeks completed after 4 cycles.
Yes, sir. Markers have come down. We'll wait for some more time, sir. Whether it is falling, we'll wait if markers are falling down again.
And then how much time do you want to wait? So what is your idea of treatment or goal of treatment? Like, what are you aiming at now? He was very sick when he came. You evaluated, you stabilized him, you started him chemo. Slowly, you build up the chemo and you plan for 4 cycles of chemo. Now, what is your goal of treatment next?
To improve his general condition and improve.
He's better. He's now walking around. He goes home and then comes back.
Yeah, he's
Otherwise,
better
he's
now.
fine now. He's better.
He's off your ventilator. He is off your NIV. He is going home and coming back for next chemo. All that's it.
Beta HCG crashed from 24 lakhs to 50,000. You should be overjoyed and cutting the cake for him, isn't it? You brought it down to so high a level, so from so high to so low, you have brought it. Are you happy?
But it does not normalize, so we'll wait for some more time.
Okay, how much time do you want to wait?
Again, 3 to 4 weeks.
You don't want to do anything in between?
I'll do imaging also, sir.
Okay.
The abdomen, chest.
CT abdomen, chest, yeah.
Because the patient was sick initially, you started him on chemo. So after the chemo, what further?
Imaging showed that the lungs has cleared, liver has cleared.
Okay, you do your markers 2 weeks later. Still, you find the same value. So
I had not done the high inguinal orchidectomy. I'll do that.
The surgeon says the values are not normalized. Would you still go ahead with surgery or not?
I'm not sure.
Okay, in an ideal situation,
GCT, it's something like what they say about GCT is that it's very much a guideline-based treatment that you should, and there's a guideline for almost every situation that you can have. So GCT, never mess around with GCT. If you're not sure, just refer, but you have to be sure for that. If there are so much situation that will happen, Normal markers, something seen in the CT scan. Inguinal orchectomy not done at some point of time, where you should do it or not. All those things, everything has got a guideline answers, and GCT is one tumor that should be treated precisely with the help of guidelines. So suppose this patient initially itself, he was having a seminoma.
Okay.
What would be the difference in approach? Will be there be any other difference in approaches? Certainly the marker was not that high. It was only something like 200 beta HCG or something like that.
Liver mets. Imagine he had liver mets also. Liver and lung mets, like your patient.
Then it's an intermediate risk seminoma, sir.
Yes,
Intermediate,
because
yes.
there is a non-pulmonary mets, it's an intermediate risk. Good. Then
So this patient also, I'll give chemotherapy with VIP regimen. So into
okay.
4.
Again, after that, there was no residual disease that was seen.
No residual disease.
In the imaging, no lung, no liver. Some say something like a 2 centimeter retroperitoneal nodes were there.
Then I'll
How
keep
do
the
And
follow-up.
the
It's
testicular tumor was there. It was 7 centimeter in the beginning.
testicular mass.
Hmm.
For the testicular mass, I can do high inguinal orchidectomy.
Okay.
Keep him
And
under
then
follow after that.
So how do you approach, or in another sense, how do you approach post chemotherapy mass for NSCCT? When should you ideally refer the patient to a surgeon? Non-seminomatous, post 4 cycles of chemo.
Tumor, if the post residual is greater than 1 centimeter, you can go for you can refer to a surgeon and do an excision.
for gems, I mean, seminoma or non-seminoma?
For a non-seminoma.
Non-seminoma. Okay.
Seminoma, how much usually?
Seminoma 3 centimeter is the cutoff. Less than, if more than 3 centimeter, we can take a PET CT and see if there is uptake.
If there is an uptake, the SUV is 6.
I'll take a biopsy from the mass.
Why do you want to take a biopsy? It is a high SUV, no? You can straight away send it for surgeon for excision. Why do you want to do a biopsy here?
You can send it to the surgeon, but in seminoma, sometimes it will be difficult for resection. There will be fibrosis.
That is not the exact, that is like you can put it another way, because 75% of the tumors taken out are only having a necrotic tissue. Based on what study? Based on? Go and look that. It is a big study which had altered the guidelines. And now the guidelines, as you said, go for a biopsy. If the biopsy says it is an active tumor, then only the surgeon is going to do a surgery nowadays. Okay. What is another indication for doing a surgery in this situation? Why do you want that 3 centimeter or 1 centimeter cut off a non-seminomatous ECT? What is the risk for a more than 1 centimeter tumor sitting there in the long run?
In non-seminomatous GCT, it can transform to a teratoma.
Yeah.
It's a possibility of growing teratoma.
The patient have a growing teratoma syndrome. So that is a risk there. So in seminoma, there is less chance of they growing for a teratomatous component. So in such, you can avoid such patient. You can avoid a big chunk of patients from surgery. Only if PET detected SUV high with a positive biopsy, do you go for a surgery nowadays? Okay. What is desperation RPLND? Desperate RPLND?
Desperate RPLND means even after treatment, the tumor markers are rising.
Hmm.
So we do an RPLND.
Okay. You are desperate that you have exhausted all of your lines of chemo. And then you desperately go for RPL. That is a situation where you will end up with an RPLD. Okay, that is called desperation RPLD. And in your patient, as soon as said the markers are not normalized, the CT shows a clearance. Imagine the liver mets are a bit there. Usually they'll hang around. Is there any role for transplant here? High dose chemo?
That's a role for transplant at first relapse or in the second relapse also. In first relapse also,
This is not a relapse.
I mean,
This is an end of treatment. This is an end of treatment value. This is an end of treatment value. This is not a relapse. Any role for transplant?
in refractory setting, I mean, no, usually in relapse only we advise transplant of either first or second relapse.
Okay. What is Bayer score?
Bayer score is for prognostication, like platinum refractory or platinum, that is tumor grows during the chemotherapy, then platinum resistant relapses within 4 weeks of treatment.
Okay, your parameters, you mark each one and put the score.
So, okay.
If the patient, because we are about to wind up, just wanted to quickly ask you, like, if the patient has got first relapse, what is a late relapse in GCT? Late relapse.
After
Define
2 years, relapse after 2 years.
After 2 years. So how do they generally behave? Is it good or bad? 2 years later.
Late relapses are generally bad.
Bad. So imagine your patient has undergone hyoid lockedectomy and resection of residual meds, everything. He's fine. He comes for follow, and he got a relapse 3 years later with a high AFP value. Metastasy is now normal. Would you plan for chemo or go for transplant? What is the basic difference between the transplant done here? What are the drugs given for transplant here? What are the name the drugs given for the autologous transplant for GCT?
High dose cisplatin and etoposide.
It is carboplatin. Carboplatin and etoposide. And you do a tandem.
What do you give before that? Before the transplant as salvage chemo? That's a specific regime for that.
Yeah, what is it?
Okay. Carboplatin and etoposide. Any idea the dose? Any idea the number of cycles? This is not a usual lymphoma or myeloma transplant that they do.
Yeah.
It's a little bit complicated auto transplant they usually do.
And I'm very, of all the auto transplants, I think GCT transplants carry the highest morbidity because the doses is just very alarming. It's 700 per meter square. Continuous infusions.
Suppose this patient was in early stage, just to finish off things, I think in the next 5 minutes. A very early stage non-seminomatous GCA germ cell.
So that chemo part, Dr.
Yeah.
Nitin has not answered. You like
Okay,
you
sure,
also question like what was the previous? That is very important. No? Any idea?
Yeah.
Chemo at the first.
It comes as 2 drugs in the beginning and then 2 drugs for transplant.
Lot of trials are named on that. Conditioning, chemo, mobilization, lot of blues, no more blues for you.
Okay,
It's called the TICE regimen.
TICE.
TI-CE. Okay.
So TI is taxanes, ifosfamide, again carboplatin, etoposide. The doses are totally different. The schedule is also different. You harvest the stem cell in the first, while doing the first 2 chemotherapies, and then you use that stem cell in the next 2 chemotherapies.
What is chemomobilization then? What is chemomobilization?
Using chemotherapy to mobilize the stem cells.
Okay, go and read.
Why?
That is very important. Huh?
Okay. Okay, now suppose this patient was a stage 1 NSGCT.
Mole.
How would you approach? He came with just with a testicular mass.
Stage 1, you have the 3 options: surveillance, then RPLND, nurse sparing, RPLND, and chemotherapy. One cycle of death.
Why do you want to do another? The imaging did not show any node in the abdomen. Then the patient will ask you, why do you want to do an RPLND if there is no node? What are the complications of an RPLND?
RPLND can cause retrograde ejaculation.
Subsequently could potentially lead to infertility, etc. So what is the philosophy of doing an RPLND if there is no nodes there? Evident in scan and the markers were normal after surgery. And surveillance or RPLND or
Chemotherapy, BEP into 1 cycle.
You follow 1 cycle, okay. Surveillance, how do you ask this patient to go for surveillance? How often do you ask them to come? And what all would you do?
In NSGCT, you have the tumor markers. So first year, tumor markers every 2 months. Then
Okay.
history and examination every 3 months. Then
Markers every 2 months and history and examination only after 3 months.
Markers and examination both every 2 months. Then
Okay.
CT about every 4 months.
Now, there are real guidelines that you have to follow for those things also. And so the patient comes and tells you again, he's very curious about the radiation toxicity. Is there any way he tells that I don't want to do a CT scan every 3 months? What would you tell? There are trials that has happened with alternative modalities like
It is now even applicable for ovarian GCTs also. The trial also looks onto that.
Ultrasound? No.
MRI.
No.
You can go for MRI abdomen also. So look into that surveillance, because surveillance, if you're asking the patient to go for surveillance, surveillance should be very strict. You're not going to give any chance of relapse or any chance of missing anything. So that surveillance is not like an ordinary cancer. So it has to be very strict, followed with the guidelines, followed with all the imagings.
So even whenever in a situation you feel the patient is not going to comply with your surveillance, you should think of other equivalent plans also.
Suppose it was a seminoma, then what are the stage 1 seminoma? What are the risk factors in stage 1 seminoma? Do you apply the same risk grouping there?
Yeah, in stage 1 seminoma, high risk factors are one is size less than 4 or more than 4. Then invasion of rotator testis.
Okay. So based upon that, this patient had a stage 1 seminoma post orchiectomy. Size was around 5 centimeters tumor, and rotator testis was not involved. What would you suggest to him?
I will suggest surveillance.
What are the alternatives? He says that he is going to go to Dubai and he does not have any insurance there. Surveillance is a little bit difficult for him.
Then 1 cycle of 1 or 2 cycles of carboplatin AUC 7.
1 or 2.
Oh, that is 1 or 2. Be specific.
Guidelines say either 1 or
What
2.
are the advantages of 1 and what are the advantages of 2? And what is the dose of carboplatin?
AUC 7, sir.
Okay. Have you given an AUC 7 to any patient?
What is the maximum allowed dosage, capping dose for AUC 7 for any patient?
900 milli.
And Abhi, what is the highest dose you have seen being given?
Okay, so one cycle or two
You can go
cycle,
to
what are the
105.
chances?
Okay, because calculation part into 7. 125 is a physiological GFR plus 25. And may I ask you one question? We usually calculate. Yeah, so now continue. I'll ask later.
No, please go ahead, go ahead. So, okay, one cycle, you have to look into what is the advantage, what are the chances of relapse after one cycle, and what are the chances of relapse after 2 cycles, and what would happen even if the patient relapses. So that's the reason why many of the people most likely practice with 1 cycle of carboplatin only. Chance of relapse are also there, slightly higher than 2 cycle, but still they are salvageable. What are the risk factors for stage 1 NSGCT? High risk factors for stage 1 NSGCT?
You have embryonal component, then presence of LVI.
And perhaps one more. Stage 3, T3 or T4 tumors also. Okay.
What is or in stage 1, you look only onto the LVSI to decide on whether you want to put the patient on chemo or surveillance. Higher stages, definitely the risk group definitely changes. And one thing I wanted to ask you, whether that is a very basic question. We said 125. What does that 25 stand for? Calvert formula. Sorry, Cogra formula. What does that 25 plus 25 stand for? When you calculate the dosing for carboplatin.
25 is the margin we give.
Why margin? Why margin?
Sure.
You're not giving any bonus marks here.
Not sure.
Take Shatner and read. There is the answer there. Okay.
Okay.
Because in the Viva, they will pick on the carboplatin and they're very old examiners are definitely going to ask this. It is a very basic thing, which is not going to change the entire oncology setting. Okay. That is a tissue factor. That is a tissue factor. You can read more on that in the Shatner.
Okay, ma'am.
So what are the late complications? What are the late, one last question, what are the late complications?
Late complications are infertility, then neuropathy, neuropsychiatric complication, second malignancies.
All of travel. Yes. All due to which agent?
Second malignancy, etoposide.
Okay. Other organ toxicities?
Due to platinum.
Why not in other tumors you have so much of late toxicities described? Continue on
We have more survival with.
Yeah. Yes. Main answer. One more.
Young patients are young.
Because cisplatin is going to stay in your for so many years. There are large studies which they have looked into what the level of cisplatin held on in the blood after testicular GCT people have been treated and have been cured on follow-up. So even at 20 years, they can pick up cisplatin levels in the blood. That is the studies. So they can trigger on the this metabolic syndrome and get all sorts of metabolic complications. Lifestyle diseases and all they can get. So in the follow-up, you done is also for
I didn't get you, ma'am.
Okay, so late complications of GCT treatment is also something that's very important to look at. So I think GCT, I think GCT, I think we'll stop for now. Anything more, Dr. Lakshmi?
nothing. There
Any
is
comments? Overall comments?
Yeah, overall comments. Nitin, you have done good. Just need to brush up and polish yourself so that the answers you left out, you can polish it. Otherwise, you do good and all the best for your exams. When is your exam coming? When is your exam?
October coming.
Okay. Okay.
Thank you, ma'am.
So just
Okay,
look
thank
into
you.
all the possible scenarios that can come. It won't be
And how-
exactly the same scenario that the patient is having that will be asked. They can go into everything related to that disease.
And GCT, don't miss out that
Dr.
your
Lakshmi, your
paper is
voice
there,
is breaking.
where
Yeah.
where the entire evolution, how that BEP evolved. That is a very good paper on JCO in 2014, 50 years or beyond. That is somewhat the headline. Please, examining PGs, please do have a look on that paper because it is very good. It can give you a lot of information on treating GCT. How did it evolve? Can you hear? I'm actually traveling.
Yes.
Can you hear?
Yes. Yes. We
Yeah.
can hear.
Oh, just Google 2014 Annals of Oncology, testicular GCT 50 years, something, some kind of a heading like that. Please go through that paper, okay?
Yes, Prashant, and I think there were
Yes.
one or two some basic mistakes here and there. Try to avoid those basic things here and there and be sharp with all those things. And otherwise, I think you did a good job. And yeah.
Thank you.
Thank you.
Yeah.
Munir, you're there?
Yes, sir. I think we can. Hello? Hello?
Yes.
Yeah.
Hello? Yeah.
Yes, Munir.
Yes, it was a wonderful section. Congrats to Dr. Nitin and for the elaborated discussion. I thank both the examiners, Dr. Sunu sir and Lakshmi madam. We can conclude the session now. Thank you. Thank you all for joining.
Thank you.
Thank you. Thank you. Thank you. Ah. Ah. എനിക്ക് എല്ലാവരും നമുക്ക്